Hello everyone, welcome back. Today we are going to talk about modern public healthcare in Malaysia. According to the Ministry of Health, the Malaysian population numbered 29 million in 2011. 63% of these were aged between 15 to 64 years. 32% were below 15 and 5% were above 65. At that time, the male average life expectancy was 72 years, while the female was 77. We had a crude birth rate of 17.5 per 1,000 population and a crude death rate of 4.8 per 1,000 population. And infant mortality was very, very low. It was 6.8 per 1,000 live births, with a maternal mortality rate of 27.3 per 100,000 live births. In 2011, the total expenditure on healthcare for Malaysians amounted to 33.7 billion ringgit or 10.8 billion US dollars. As a percentage of GDP, this was less than 5% of GDP at that time. This gives you a breakdown of the Ministry of Health budget in 2011. Well, the top three causes of death in Ministry of Health hospitals were heart disease, respiratory diseases, and infectious and parasitic diseases. Childhood immunization coverage was more than 90%. In pre-independence Malaysia, work on providing public health care began in the 1950s. Between 1953 to 1956, a scheme called the Rural Health Service Scheme was started. The first rural health center was built in 1953. This provided maternal and child health services with very minimal curative services. By the end of the 60s, this number had grown to 8 main health centers, 8 health sub-centers, 26 midwife clinic cum quarters, and 18 maternal and child health clinics. This is a pyramid of health services in Malaysia. As you can see, this is a 3-tiered system with rural health services delivering healthcare delivery at the district level. There is, of course, the secondary and tertiary care level, and of course a tertiary level. There are public and private healthcare providers in Malaysia. The Ministry of Health is the main healthcare provider, and this ministry operates a wide network of hospitals and clinics throughout the country. Currently, there are more than 100 government hospitals throughout the country with nearly 42,000 beds. These hospitals are supported by almost 1,000 health centers, nearly 2,000 community clinics, 5 flying doctor services, more than 100 One Malaysia health clinics, and 6 One Malaysia mobile clinics. These are just some pictures of modern hospitals in Malaysia, as well as mobile and static clinics. This table gives you the information which I have just repeated just now. Now in Malaysia, the share of private healthcare expenditure is rising and rising rapidly. In 1981, it was less than 6% of the total expenditure in Malaysia. This had grown to just barely 8% in 82, but in 2009, this had formed 45% of the total healthcare expenditure in Malaysia. The launch of the Privatisation Master Plan in 91 included healthcare for private ownership, where 12 public hospitals were among 150 agencies identified for privatization in Peninsular Malaysia. There has since been a proliferation of private healthcare facilities, with 174 in 1992 and more than 600 in 2011. KPJ Healthcare Berhad, which is a major private healthcare provider in Malaysia, initiated acquisition of private hospitals in the 80s. Parkway Holdings and Pantai Holdings did the same from the 1990s, with Pantai Holdings now the biggest healthcare provider in Malaysia, Khazanah Holdings was listed at the Kuala Lumpur Stock Exchange in 1997. By 2005, it operated 7 hospitals with a total capacity of 1,000 beds. Further steps were taken by the Ministry of Health to privatize healthcare, including the outsourcing of a range of services in public hospitals. And these are the services which have been privatized wholly or in part in Ministry of Health facilities. From 1980, private healthcare has grown rapidly, from 50 private hospitals in 1980 to 220 hospitals in 2011, indicating a growth of 440%. So now, private hospitals outnumber public hospitals in Malaysia. These are just some of the pictures of private hospitals in Malaysia. At the district level. Things like family health services, which covers maternal health, like antenatal clinics, safe deliveries, domiciliary deliveries, postnatal care, and family planning, and also screening like pap smears. There is also child health care, which provided care for infants, immunization for toddlers or preschoolers, school health, and also nutrition services. There is, of course, the primary health care services, which is provided through outpatient clinics, hospitals, health centers. Disease control can be divided into vector-borne disease control for diseases like malaria, as well as communicable diseases like food and waterborne diseases like cholera, typhoid, dysentery, etc. Workers' and environmental health are also not left out. These consist of health promotion in work sites, health screening of workers, and worksite inspection together with the Department of Occupational Safety and Health and the Department of Environment. A food quality control program provides such things as surveillance, where premises are inspected, food is sampled, and enforcement is carried out. Where necessary, prosecution is enforced. At the district level, health education programs are also carried out, with health education activities for the above and healthy lifestyle promotion for the above too. Environmental sanitation and a national water quality program is also carried out at the district level. This looks into sanitary facilities in villages, for example, the provision of toilets and the provision of a safe water supply. Silage and solid waste is also looked into. The scope of healthcare in the health clinics has grown over the years. In the first phase of development, over a period of 10 years, from the 1960s to the 1970s, only maternal and child health care was provided. This was in addition to family planning and outpatient health care. This was augmented in the next 20 years in the phase 2 of development, when dental health care, lab services, a pharmacy, and home visits were added to existing services. In the phase 3 of development, from the 1990s until now, this has expanded tremendously. A lot of other services have been added, as can be seen from this figure below. The current scope of services in health clinics can be divided into curative services, family health, dental services, nutrition and dietetics, health education and promotion, home nursing and care of the elderly, rehabilitative services, environmental sanitation, well-women clinics, adolescent health, and community mental services. The new primary health care clinic has these features. It has features in promotive, preventive, and curative care. It is close to the homes of people who the clinic are serving. It is comprehensive in nature. It is a one-stop center, and there is a team approach to lower the cost of maintenance. The introduction of specialized care in primary care has also become a reality in recent years. And these healthcare clinics also now provide pre-hospital care and disaster preparedness. There is also integration with the secondary healthcare with a referral system. An integrated approach called REAP, or Reviewed Approach of Primary Healthcare Clinics, were introduced in recent years. This looks at the primary healthcare clinic as being part of the community, working with the community and hospitals, as well as non-governmental organizations and private healthcare providers. That is all for my second lecture. In my next lecture, we will talk about the future of Malaysian public healthcare.